Hello, everyone. Welcome to another session of Zooming Through ID with Dr. Gopal. I'm Dr. Gopal. I'm one of the infectious disease specialists at Broward. I've been practicing for 20 years. I'm the APD for the fellowship program here for infectious disease. I'm also the chair for antibiotic stewardship for the 4 hospitals for the district and chair for infection control at Broward North. Zooming through ID is a great program that we are doing it. I'm spearheading at Broward North. It gives an opportunity for internal medicine residents to research a particular topic. And then this is a time where they can showcase what they have learned. And today I have Dr. Varshini Mali Redigari today with us. And without further ado, I will let her take over.
I'm just going to share my screen.
Okay, great. I can see it. Yeah. Okay, go ahead. Yeah.
Okay, so my topic is on TB. So just the objectives, I'm going to do an introduction to the topic, definitions, and then screening guidelines for tuberculosis, and then the diagnosis of tuberculosis and the treatment as well. So just an introduction, tuberculosis. One second, I just got to move some of the things in my screen. Okay. So introduction, in 2023, the World Health Organization estimated that 10.6 million people fell ill with tuberculosis worldwide. TB is the second leading infectious killer after COVID-19 with about 1.6 million deaths from TB in 2021. It has the highest burden of TB is found in low and middle income countries, especially like Southeast Asia, Sub-Saharan Africa, and Western Pacific. India, China, Indonesia, the Philippines, Pakistan, Nigeria, Bangladesh, and South Africa account for about 2/3 of the global TB burden, and drug-resistant tuberculosis is a growing challenge. About 450,000 people developed multi-drug resistant tuberculosis in 2021. So these are just some quick facts about tuberculosis and why it's so important to know how to diagnose, treat, and how to screen, diagnose, and treat tuberculosis. So some definitions. So in literature, it's not very consistent. The new terminology for tuberculosis is basically tuberculosis infection and tuberculosis disease. So these are the newer terms that are used instead of latent tuberculosis and active TB. So it's very important to understand this new terminology. So Mycobacterium tuberculosis infection is either cleared or contained via innate and acquired immune defense mechanisms. Individuals whose immune system initially contains the organisms are asymptomatic and non-infectious, though likely harbor potentially viable organisms. This is basically referred as TB infection. The previous term for this was called latent TB, and this may be misleading. So in latent TB, usually like it states that they cannot spread the disease, but in active TB, they can spread the disease. Just to clarify, the new terms is tuberculosis infection for latent tuberculosis, and then tuberculosis disease for the newer term for active tuberculosis. So for screening, who should be screened for tuberculosis? So basically, a lot of times it's the people who are at most risk for exposure to TB. So close contacts of patients with untreated respiratory TB disease, casual contacts of patients with untreated respiratory TB disease, people who use illicit drugs, residents or employees of homeless shelters or correctional facilities, and healthcare workers as well. To go into more specifics, I guess, in terms of high risk, it's important to test patients when they have HIV infection, transplant, chemotherapy, or other immunocompromising conditions, lymphoma, leukemia, head and neck cancer as well. If they have an abnormal chest radiograph, if they have any like fibronodule changes, it's also important to screen, as well as silicosis and renal failure requiring dialysis. And also, if they're being treated with a TNF alpha inhibitor, it's always important to screen for tuberculosis prior to starting that medication. And then moderate risk group, people with diabetes and systemic glucocorticoid use. And then some slightly, I guess something else to consider is slightly increased risk. If people are underweight, if they're smoking cigarettes, if the chest radiograph shows solitary granulomas, or individuals born in or former residents of countries with high incidence of tuberculosis. So these are just important things to look out for when screening patients. More information that I read about screening is that close contact, this is basically defined as an individual who shares a close space with a patient with untreated respiratory TB disease for greater than or equal to 4 hours per week. And then I read another study that said that this should also include people living in the same household or frequent visitors to the household. And this may also include people at work or at school. So basically, the evidence of transmission is defined by the detection of TB disease among these contacts. And basically, you have to do like the positive tuberculin skin test or like an interferon gamma release assay. So that's kind of the testing that you do, screening guidelines for the people who have close contact. And then if the first test is negative, close contacts of the patient with pulmonary tuberculosis should undergo a second screening test within like 8 to 10 weeks as well. So even if they have a negative test, it's important to follow up with a second screening test in 8 to 10 weeks. And then in terms of some more populations, in terms of screening, the annual screening is warranted for residents and employees of homeless shelters and correctional facilities because they're at a higher risk of TB exposure. In regions with low TB incidence rate, most healthcare workers in facilities with low tuberculin skin test conversion rate, they don't need to undergo routine serial tuberculosis screening. This is something that I read on UpToDate. Basically, if they get the screening and when they're newly employed, it's not required to undergo routine serial TB screening every single year. Only baseline TB screening with like a interferon gamma release assay or a tuberculin skin test should be performed, but not like the full process. They don't have to undergo the full process. And then serial TB screening may be reasonable for healthcare workers when they're at increased risk of occupational exposure, especially the pulmonologists and the respiratory therapists who are more in contact with the tuberculosis patients. And in certain settings as well, like in the emergency department, this is prior to knowing if they are positive for TB and such. These emergency department physicians and workers, they're exposed to the patient. And this is an algorithm that I found on UpToDate. It's basically lays out the framework for screening guidelines, the approach to like diagnosing tuberculosis in adults. A lot of it is like pretty simple. You just had to follow it through. People who are at increased risk of tuberculosis, they have to undergo the interferon gamma release and the tuberculin skin test. And then if you choose to do the interferon gamma release assay, there's like the positive, indeterminate, and negative, and usually it's followed up. You have to follow up basically with like chest x-rays and such as well. So if you choose the interferon gamma as the initial test, if it's positive, you have to treat for TB infection after excluding active TB. If it's indeterminate, then the patient has, you have to figure out if the patient has received the BCG vaccine. If they have, and if it's positive, then basically you have to treat the infection. If the interferon gamma release assay is negative, then it goes on to here where it's the TB infection is less likely because they had received the vaccine prior, and the interferon gamma is negative. So basically, this explains that this is a false negative that can occur. And then if it's like indeterminate, then you want to do the tuberculin skin test, and that kind of leads you into which if you want to treat or if you don't want to treat as well. And then this is when you do the tuberculin skin test as the initial test. If it's positive, then these patients, you want to perform the interferon gamma to rule out non-tuberculosis mycobacterium infection. And if it's in a high TB incidence setting, then you want to look at if the patient is at high risk and look at the treatments for that as well. And then if it's tuberculin skin test is negative, then it's less likely if they have a negative screen that, that they have the tuberculosis. It's like, however, you also have to consider like false negatives can occur. So this kind of helps break down, how to screen for tuberculosis and how to diagnose as well. But this is from Up to Date, so you can always refer to that. And then in terms of diagnostic tools in terms of microbiology, there's the sputum smear with the Zeal-Nielsen staining and the fluorescence staining. You can do the culture with the Lowenstein-Jensen media, as well as drug sensitivity testing. And then you have like the rapid molecular diagnostic testing. This is where like the gene sequencing and the Mycobacterium tuberculosis PCR testing. And then this is also something that I read. There's something called a line probe assay for Mycobacterium tuberculosis complex and the detection when it's resistant to rifampicin and isoniazid. Some other supportive diagnostic tools, the radiograph, basically the chest x-ray is a screening tool to increase the sensitivity of the diagnostic algorithm. So if they test positive with a tuberculin skin test or the interferon gamma, you can also always get the chest x-ray. And any abnormality on the chest x-ray should be evaluated with also the microbiological tests. So diagnosis of TB is based on the chest x-ray and also clinically if they are actively showing symptoms as well. And then the tuberculin skin tests and the interferon gamma are typically used as well as screening tools. So on chest x-ray, you can see you'll have consolidations as well as hilar enlargement in a chest x-ray that shows like tuberculosis.
Just, yeah, that's great. Just quickly about, can you hear me? Yeah.
Yes.
Just quickly about, I mean, I know you talked about, this is great about pulmonary tuberculosis. Just a word about, other extrapulmonary TB can occur. I mean, I'm sure you saw a case, right? CNS TB is common. I mean, it can be either meningitis or focal tuberculomas. So the diagnostic criteria, I mean, diagnosis will be definitely we need, lumbar puncture in that case. Sometimes it can be TB lymphadenitis. So then we need biopsy and pathology. If there is TB from bone and joint, it can be like vertebral osteomyelitis, thoracic or lumbar, and usually we see anterior verging, and sometimes I've even seen psoas abscess. So chronic osteomyelitis and arthritis, so TB has to be in the differential. Pleural effusions, usually that will be lymphocytic effusion. And then pleural biopsy is needed for that type of, and there will be low bacillary burden in the pleural fluid. We may not have too much, AFBs there. Pericardial effusion can also happen. Again, it will be lymphocytic effusion. So the diagnosis there would be pericardial biopsy. In terms of genitourinary TB, it will be sterile pyuria. So that is the classic for, you will have pyuria, but it will be sterile. That is the genitourinary. And GI can also happen, and usually PCR or again pathology will be the diagnosis. And then we do see, if it is disseminated, we can obtain blood cultures also in addition to that will be in advanced HIV patients. So those will be, taken for that. So those are some of the extra pulmonary TB diagnostic tools. Yeah, go ahead. Yeah.
And then I wanted to go into treatment of tuberculosis, a little bit more detail about that. So the treatment of latent TB, this is basically TB infection is the term that they're using nowadays. Some common regimens, it's with isoniazid daily for 6 to 9 months. You can also do isoniazid with rifampicin. I can't pronounce that, but that medication weekly for that's also for a few months as well. Or you can just do rifampicin for daily for 4 months as well. And this table gives you a little bit more in detail about the medication dosages. You can see here, it's like
the daily treatment we do, 9 months. Yeah, the weekly one will be 3 months.
3 months or 3
And
months.
it's happened in weekly. Yeah. That's a very popular option these days, the weekly one.
Yes, because of compliance and everything, it's very difficult to get a patient to take medications for the extended period of time of like 6 to 9 months for sure. So this is definitely the more popular option as well. And then I have this this slide. This goes over the treatment of active tuberculosis. You have the standard 6-month regimen. So you have isoniazid, rifampicin, pyrazinamide, and ethambutol. And then this is for 6 months. And then you have the continuation phase for the next 4 months with isoniazid, rifampicin. And this part basically goes over more detail about the dosing. It gets a little complicated, but basically you can see when it's like the 4-drug regimen, it's 7 days a week. For the first 2 months, it's at a higher dose, and then basically it's like 5 days a week. Sorry, it's and then it goes on to be like fewer doses basically. So in the first 2 months is when they receive the most amount of medication. It's a lot of detail, but I think this chart does a very good job of breaking down the doses and the dosing intervals as well.
And always we have to include pyridoxine for the neurotoxicity for the INH.
Yes, B6, yes.
Yes.
And then I have this slide about the treatment of drug-resistant tuberculosis. Like I mentioned in the very first slide, basically there's many cases of drug-resistant tuberculosis. When TB is resistant to the first lines of medication, then the treatment becomes definitely more complex and more prolonged. If they're resistant to isoniazid or rifampicin, the treatment, it's going to be much longer. It's going to be 18 to 24 months. And you have to include second-line medications. This includes fluoroquinolones like levofloxacin and moxifloxacin, as well as injectable agents like amikacin or capreomycin. And then you have extensively drug-resistant tuberculosis. This is when it's even more drug-resistant. This is basically an area where medications are being, worked on and developed. So these medications, they're treated with specialized agents, newer drugs, and these are the 2 medications as well that I saw.
Bedaquiline. Yeah. These will be, we'll have to get it from CDC and from the TB specialized hospitals and stuff like that. And in terms of the duration, if somebody has cavitary TB, we usually give them treatment for 9 months total, pulmonary cavitary TB, and especially culture is positive at the end of, at the end of 2 months, we do cultures and see, and if the culture is still positive, we'll extend it to 9 months. And CNS tuberculosis is another where we usually give treatment about 9 to 12 months. Sometimes, we go for a year. Bone and joint also another one where duration can be anywhere from 6 to 9 months total.
And then this is a chart that I found with some of the more secondary line medications as well as some of the newer medications as well. I think it's like obviously you have your primary medications, the first line ones, and this kind of goes into detail about the secondary medications for more drug resistant tuberculosis.
And just quickly about the toxicities. I mean, hepatotoxicity is the one we see with isoniazid, and also pyrazinamide and rifampin. All of them can cause liver toxicities. Retrobulbar neuritis is something that we see with ethambutol. And pyrazinamide can cause joint pain, arthralgias. And we talked about the use of, B6 because of the peripheral neuropathy that we see with INH.
Yeah, basically, this is kind of like a general guideline, key considerations when, trying to treat tuberculosis. A lot of these regimens are extended with multiple medications and for an extended period of time. So adherence is always something super important to look at. It's important, critical to prevent resistance and also to cure the disease. Compliance with the medications is also very difficult. So we always want to ensure that, the patients are on the best regimen to treat the disease, as well as making sure that they are consistent with taking the medication. Like Dr. Gopal has mentioned, side effects are very important to monitor as well with these medications, especially like liver function tests, routinely monitoring that because a lot of these medications have side effects on the liver. And then follow-up testing, sputum and chest x-ray to see the response to treatment. And then as well, like isolation may be required for for the contagious patients. So these are just a few key points to look at when you're treating a patient with diagnosed tuberculosis and ensuring that the patient, gets the appropriate treatment.
Excellent, excellent. And just one key point about rifampin. Rifampin, basically, the way I remember is it chews up pretty much most of the drugs. So oral anticoagulants is something we have to be very careful about. Contraceptives, um, and then fluconazole, it interacts with the rifampin. Many of the patients, if there is HIV and TB co-infection, the rifampin does interact with the protease inhibitors, NNRTIs, even the CCR5 inhibitors, all the new HIV, all the HIV drugs, we have to be very cautious with rifampin.
So these are my resources up to date, Mixap and Amboss. Obviously, TB is a very vast topic. I try to give you the highlights about the most important key takeaways, but it's very complex and very detailed. So a lot to read about.
Excellent, excellent. Great job. So this is wonderful. I think I like you mentioned it's a vast topic, but you went into the details about the screening, the new terminologies, touched up upon the treatment, and this was great. Wonderful.
Thank you.
Okay, great. Thank you for joining. Okay, bye.